Hello, this is Dr. Mary Grady, and Hello Nursing 122. We are going to now talk about the concept of metabolism, but to be more exact, the exemplar of diabetes. And there's a lot of things. This is going to be a short overview. I'm not going to cover all of this PowerPoint. It's just an introduction to the types of diabetes. And if you go to overview, that is where I want to start on this PowerPoint. Diabetes is a disorder of hyperglycemia. It's a disturbance in your carbohydrate, protein, and fat metabolism. There's problems somewhere with your insulin secretion or how insulin acts in your body, or maybe both. But these problems lead to more problems. And diabetes is something that's been contributed as a major cause of MI, strokes, renal failure, blindness, peripheral vascular disease, because this blood sugar, when it's too high in your bloodstream, it's causing damage to those vessels, and that blood flows every part of your body. Now there's 4 types that are listed. Type 1, a type 2, and a gestational diabetes. And then they always, in every medical thing you will ever see, throw in something called other. That's when we don't know what's going on. But let's look at the different types there. We're going to get into those in a little bit more in a minute. As a matter of fact, let me kind of go back here for a second and tell you something very interesting. The people that fall into type 1, when I did my research, it said it was about 10% of the cases, 5 to 10. Type 2, believe it or not, is 90 to 95%. That's a lot of folks. Gestational was about 2 to 5%, and this other was 1 to 2%. And one of the things that could fall into other could be trauma that could have caused the diabetes, or maybe long-term conditions that have damaged that system. When you look at the parts of the pancreas is the important organ we're talking about here. There's different cells in the pancreas that are responsible for different things. And in our case, it's those beta cells that are destroyed. And when you lose beta cell function, you lose that ability to have insulin. Glucagon, the alpha cells that take care of that, glucagon is what causes our blood sugar to go up. Insulin is what packages our high blood sugar and takes that sugar and stores it in the cells. So those are just a few of the main things to kind of keep in mind there. So let's go to the next slide. And this is something you already know. Your body needs a constant supply of glucose. And you have to have glucose. I have to have glucose in my brain all the time. I have to have glucose in my body to have the energy to keep going. So this is very important. And to know that your body's always playing off the insulin and the glucagon. My body knows if I lack insulin, the glucagon should hopefully know my blood sugar is too high and kind of stay out of the picture. But if you start to make too much glucagon and you don't have enough insulin, you're going to be hyperglycemic. Type 1, okay? Type 1 is something that usually occurs before the age of 30, but it can occur at any time. It's thought to be autoimmune, that or genetic. But autoimmune means it's an inflammatory process from cell destruction where your beta cells are being destroyed over time. Usually when beta cells, 80 to 90% of them are destroyed, you lose that beta functioning, which means you lose the ability to make insulin. And some of the causes, like I said, is idiopathic. They don't know. They've also found a huge genetic component to type 1 diabetes where some people are diagnosed maybe at 18 months and somebody might be diagnosed at 22. But it's kind of like when those cells have really reached the point where they're destroyed. You might have them destroyed from the day you're born, but it's not till they get to 80 to 90% of them that it starts to show the lack of making insulin. So, and sometimes when you have a type 1, in the beginning, they may still be making insulin occasionally, and they don't really need as much coverage as they thought they would. And people start to think, oh my gosh, I'm cured of this. Well, no, it's just a honeymoon phase. You still got a little bit more beta cells going on, and it's going to take a while for those to kind of peter out. It's a genetic disposition, I said before, occurs mostly in childhood and adolescence. And there is your risk factors there. This environmental component, some of the environmental components with diabetes, they have found like chemical toxins found in smoked and cured meats that have been linked to this. Maybe it's something in the air that you breathe. The genetic disposition, sometimes it's environmental triggers as well that triggers this loss of beta cells, or for your body to just click on this destruction of beta cells that you were prone to. Sometimes a viral infection like mumps, rubella, things like that can trigger this component to kind of go on. Clinical manifestations, your blood sugar is too high. You have a breakdown of body fats and proteins, and that develops something called ketosis, where you start to have a lot of ketones that show up in your urine. And over time, this isn't very good because it puts a stress on the body system. It puts a stress on the kidneys and all the other body systems that are having to circulate this blood flow. So lack of insulin is hyperglycemia. Glucose cannot enter the cells without insulin, and that sugar has to get into the cells in order to feed my cells. So that is a problem. The manifestations here, before I get into this, I just want to remind you that hyperglycemia causes hyperosmolality. It draws water from intracellular spaces into the circulation, and this increases the blood volume, it increases the renal flow, and it's almost like hyperglycemia acts as an osmotic diuretic. And so because of that, you have people with polyuria. They're going to the bathroom a lot. Another thing to keep in mind is when your renal threshold is like about 180, and when it gets past 180 in your urine, in your kidneys and in your bloodstream, it spills into the urine, and that's when you start to detect with a urine strip, that person has urine, polyuria, and has glucose in the urine. If you also think of the signs and symptoms, this polyuria makes you prone. You could be dehydrated because maybe you're voiding so much and you have a decrease in that intracellular volume, like I said before, because everything is being drawing of the water from the inside to the outside with the blood flow to kind of in the bloodstream to keep things flowing, to increase the urination. So dehydration, you would be prone to this. Your mouth gets dry with all of this, and your thirst sensors start to get activated, and so you have polydipsia. You're fatigued because you don't have any glucose getting into your cells. And this decrease of energy stimulates hunger as well because the body says, I gotta eat. So you have polyphagia. But despite all the food intake that the person takes in, as the body loses water, it breaks down proteins and fats because it's not getting the glucose in the cells. And this can contribute to blurred vision because of this osmotic effect that I had said about drawing water from intercellular into circulation. And this blurred vision, this osmotic effect can cause the lens of the eyes to swell. So you can see what an important part insulin plays on everything. So if you are a type 1, you are going to need insulin to survive. Type 2, that is adult or childhood onset. Used to be when I was in school, they called it adult. But we have so many children now that are in such poor health and obesity that it's now become adult or childhood onset. So it's formally known, like I said, as adult, but it can occur at any age. But usually middle age is when you see this. And this results from something called insulin resistance, with a defect in how your insulin is secreted. And the level of insulin produced varies from person to person. You can produce insulin, but it is impaired in functioning due to the insulin resistance, where the cells are just not taking it in. Insulin resistance exceeds the ability of the pancreas to compensate. And over time, the pancreas goes, I am so sick of making this insulin that nobody wants. I'm giving up. And so then you don't get enough insulin for the body. So risk factors that put you at risk for type 2 is if it's a genetic component, if you have parents or siblings. If you're obese, they're thinking that leads to insulin sensitivity. If you're not active, they have found different races and ethnic groups are more prone to this problem. A history of gestational diabetes during your pregnancies, polycystic ovary syndrome, hypertension, and metabolic syndrome are just a few. So what are the clinical manifestations? Unlike type 1 where you notice it right away, usually once the flip is switched and the pancreas quits working, this one might be a slow onset. But it's similar to type 1 in the fact that you're drinking a lot and you're eating a lot. You have insulin to prevent fat breakdown usually, but not enough insulin for energy and cells. Cellular resistance of insulin is increased, like I said, by obesity, inactivity, and illness and medication and all of that. But basically, the treatments for this begins with trying to control this blood sugar and working with people with their diet, their weight loss, and their activity level. Those are some prime things to work with so that you could, this is almost reversible in the beginning if people can get this under control. We need to remember that diabetes involves all body systems, regardless of the type, and it alters your circulatory system. And it leads to a lot of the neuropathies that we've talked about before. And because of all these systems involved, and because of the autoimmune component they feel, you're more susceptible to infections, things not healing well, more acceptable to periodontal diseases and problems in the feet. So if I have a diabetic, two of the things I really need to work on with them is making sure that they understand what it means to be too high and what it means to be too low, so hyper and hypoglycemia. Here's a few responses here to just kind of look at and pay attention to with hyperglycemia that you might see in your patient. That they may spike at certain times, like in the middle of the night, certain syndromes that are called, and something called DKA. If it goes too high, there's increased glucagon levels, there's not enough insulin, so all your body's doing is just adding more sugar to the blood sugar that's already high and causes a lot of issues. DKA, just know that the ketoacidosis, diabetic ketoacidosis exists, but we're going to get further into that when you get into your trauma or your later nursing classes. So as far as the ketoacidosis goes, those are just slides for you to kind of look at and keep in mind about how treatment occurs. Okay, so I just want you to keep that in mind, and you can go past that. And just know how that's commonly done. So, and to know that too high means if a normal blood sugar is 60 to 100, and some sources say 110, anything above whatever your agency says, 100 or 110, you know is going to be hyperglycemia. Now, hypoglycemia is when your blood sugar is too low. That means it's below 60. And it's really common in type 1 because a lot of times people have intake of alcohol, drugs. It could cause the insulin to not be as much insulin as you need. Maybe you've exercised too much, and you start to get to the point maybe you're not aware that you're even hypoglycemic. So the signs and symptoms of hypo and hyperglycemia that we've went over in class are things that you need to go over as well to kind of prepare for the exam. Hypoglycemia, when somebody is too low, they need sugar. So what they usually say is give them 15 grams of rapid acting sugar. So if you need 15 grams of sugar, usually 3 glucose tablets is 15 grams. A half a cup of juice would be 15 grams. 8 ounces or half a cup of regular soda, 8 ounces of skim milk, and 5 lifesavers. But what they recommend is never add sugar to juice, because they feel like that's like going to be a quick spike and then a quick drop. If you're in the hospital, usually blood glucose below 50, they have protocols to follow. We don't want you to get too low, because not having enough sugar to your brain can result in seizures and a coma, altered level of consciousness, and you need to make sure that we are taking care of that. Now, one of the ways to take care of that, what did I just do, is in the hospitals, they will have things like, as PRNs, the glucose tablets, or being able to give glucose solutions, or having glucagon or 50% glucose that can be pushed in an IM, or pushed IV, or given IM or sub-Q, that will help bring this blood sugar up. One of the things that they talk about is use the 15 to 15 rule. You usually wait 15 minutes after you've given someone 15 grams of sugar. At this time, after 15 minutes, if it's still low, give another 15 grams. So that's the rule of 15-15. I do want to go in to say that there are a lot of alterations from this disease, no matter what causes it. And these are just a few that was spoken of before in the circulatory system. But blood flows everywhere. So it could be a lot of issues with the retina and with neuropathy. So keeping those in mind. And the peripheral nervous system. And the autonomic nervous system. So you see here, it can be every part of your body that results from like complications with diabetes, which means a lot of collaboration with people, diet, and exercise. And that brings us to diagnostic testing. I'm going to stop here on this particular PowerPoint, but I want you to go back and I want you to look at this testing and pay attention to what these tests are that you're doing to diagnose for diabetes. So this concludes the end of Part 1, Introduction to Diabetes, and I'll be talking with you again soon. Oops, if I can say I will. Goodbye.